We are live, please.
Very good evening, and it's my pleasure to organize this webinar, which is for the general ophthalmologist. And it's what happens when you see a patient with peripheral ulcerative keratitis come to your clinic. So how do you investigate? How do you manage? And do you need to refer this patient, or can you manage this patient in your own clinic? So I'm very happy to also introduce our chairs for this evening. We have Dr. Paras Mehta. As I think most of you know, Dr. Paras Mehta is a senior cornea surgeon practicing in Baroda in a very well established 25-year-old plus practice at Sameep Eye Center, and she's one of the chairs for this evening. We are waiting for the others to join in. We also have our expert panelist, Dr. Fahim Raja, who is from INS Ashwini, assistant professor there, and Dr. Saujanya Viyuri, who is a cornea specialist from LV Prasad Eye Institute in Vijayawada. The other panelists will join in as the evening goes into night. The format for today is that we have two very interesting talks. The first one by Dr. Radhika Natarajan, and I'll just introduce her just before her talk. And the second one will be by Dr. Ritu Arora. And followed by that, we will have presentations from our young ophthalmologists who will be presenting various clinical cases, real life cases, which have come to them. And this will be discussed by the panelists. So without much more ado, I think we'll go ahead. I would, at this onset, just like to thank Dr. Santosh Honawar and Dr. Manoj Mathur, who are the General Secretary and Honorary Treasurer for the All India Ophthalmology Society, who run this series almost twice a month, I think. And I have been part of this for a few years now, and it's been a great journey. Also want to thank Professor Titial Sir, who's the president of AIOS, for the opportunity to host this webinar. We'll move on to the first presenter, that is Professor Radhika Natarajan. Dr. Natarajan, as I think most of you know, is the head of Department of Cornea as well as Refractive Surgery at Shankar Nethralaya. She's a very senior cornea specialist, and she's always a sort of a usual participant in most of our webinars, if not, willing or unwilling. And I appreciate that.
Very willing.
She recently traveled, and she's giving us time. She must be so jet lagged for this webinar. Thank you very much, Radhika, for taking part. And I would like you to start the topic, get everyone warmed up by talking about the evaluation and management of Moehrens ulcer. Over to you.
So thank you so much, Dr. Somshila, for having me here, and thanks, AOS. I can't think of a better person than Dr. SS to hold this particular webinar because, as we know, she's the expert in ocular immunology, be it PUK or scleritis or uveitis. She's got a lot of treatment experience as well as research. So I'm really honored to be part of, her group today over here. And I'm looking forward to discussion by the, senior experts like Paras and others in this forum. So let me share my slides in a bit here. Is my screen visible?
Yeah. Yes, doctor.
Yeah. So basically, I'm Radhika from Shankar Nethralaya, and I'm going to talk to you about a common entity seen not only by cornea specialists, but also by general ophthalmologists, which is the Moehrens ulcer. So Moehrens ulcer is usually idiopathic, usually a unilateral kind of entity, which, as you can see in the picture, goes on melting the peripheral cornea. So it can be unilateral or bilateral. It could be moderate or severe. It can occur in younger or older patients. But usually the clinical variants don't follow these textbook stereotypes. But it may be safe to say that the occurrence is quite more common in male patients compared to female patients. It's very important to take a history before labeling something as Moehrens, because if we see a malar flush like this, or joint deformities or respiratory problems, then we must be alerted to the possibility that we may be dealing with a secondary peripheral ulcerative keratitis rather than an idiopathic Moehrens itself. So Moehrens by definition is either unilateral or bilateral. But the striking feature in Moehrens ulcer is pain is usually very much out of proportion, whereas in peripheral ulcerative keratitis, a painful condition when it is secondary, but not as much as in Moehrens. In Murens, you have the characteristic overhanging edge, which I will be demonstrating it to you. And it's important to know that whereas a PUK of other etiology has an undermined edge usually. Murens usually doesn't have a specific etiology, so the systemic investigations are negative, which are positive in a secondary PUK. Usually does not show scleral involvement as well. So this is the way a typical Murens progresses. You can see the patchy infiltrates, they are coalescing and they're forming a gutter in the peripheral cornea as the arrow progresses, and you can see a frank melt in the peripheral cornea. The picture below shows you the overhanging edge that I was trying to describe to you. It's important to note this because for diagnostic purpose, it helps us. Not only that, at the time of treatment, we need to treat this also because it is a source of a lot of inflammation and it is also an impediment for epithelialization. So many peripheral lesions, which are degenerations, can also, mimic this condition. But if you see the terians over there or the senile furrow over there, the eye is completely quiet because they are non-inflammatory in nature. The epithelium is intact over it, and these usually start in the 12 and 6 o'clock cornea. However, by contrast, when you see the Murens over there, the eye is very much inflamed and the disease starts and progresses from the area of the interpalpebral regions. So there are some other proposed etiologies for a Murens ulcer that, it can follow infections like helminthiasis and hepatitis, or it can follow injury or surgery. So why does that happen? Two reasons. One, because any inflammation increases the expression of the corneal antigens, which were suppressed till now, and therefore autoantibodies are produced. Second reason is when the antibodies are directed to the infection due to molecular mimicry, they can cross-react with the antigens in the cornea also. So these are the proposed etiologies, never been proven without doubt. But both cell-mediated and humoral immunity we know are involved in the pathogenesis of Murens ulcer. It's important to know this for the background of the treatment because the immunosuppressants that we use like cyclosporin corrects the balance between the suppressor and the helper cells, and the antimetabolites that I use offset the high concentration of plasma cells and lymphocytes in the vicinity of the peripheral cornea. And likewise, conjunctival resection has a role in warding off all the immune-mediating agents from the area of the ulceration itself. So histopathologically, what do we see in a Murens ulcer is plenty of infiltration, particularly lymphocytes and plasma cells. It goes way down to the deep cornea, but many of the times the Descemet's membrane itself is spared. That is why there was a myth that Murens does not perforate. That's not correct. Even though the DM is spared, when the epithelial defect is open, the tear lysozymes are getting in, the perforation can always result in a Murens ulcer. The goals of treatment of Murens ulcer are very clear. You have to control the inflammation. You have to build the tissue thickness that was lost. You have to promote epithelialization. Otherwise, the rebuilt tissue will get lost to the same inflammation, and you have to treat sequelae like scar or glaucoma or cataract. So for this, you can do medically using steroid and immunosuppressants, and surgically using glue, bandage, contact lens, amniotic membrane, or patch grafts, which to use when I will blow up that diagram of pathogenesis to explain to you. So immunosuppressants, by definition, suppress the immunity. So they have to be given when the disease is just smoldering. So they take 2 weeks to act. When the disease escalates and the complement cascade is activated, you need to give oral steroids to the patient. In the next stage, when the immune complexes are liberating the collagenases and the melting of the cornea has started, you need to pulse the patient. This can be using several agents that we will see shortly. In the last stage where the tumor necrosis factors and the MMP agents are melting the cornea, only biologics seem to work at that stage. So it's important to understand this because in an acute melt, you cannot expect immunosuppressants to do the job immediately. On the other hand, biologics for every simple Murens would be an overkill as well. So the first caveat was to control the inflammation. Before that, we need to take a look at whether there is any infection. As you can see, a yellow patch in the cornea that needs to be scraped and infection needs to be ruled out. Conjunctival excision has got takers and not, but I tend to do it. And then the patient can be started on topical and oral steroids. In the next stage, in moderate cases, immunosuppressants need to be employed. When is that? When the disease is bilateral or severe disease in a unilateral patient, when the disease recurs again and again, and especially when you want to do a surgery like patch graft in order to protect the outcome. So many agents are there. This is a busy slide. I used to use azathioprine earlier, but nowadays I have shifted to methotrexate as well as mycophenolate mofetil. They seem to work better at my hand. Can use the cyclosporin and tacrolimus, but not as standalone agents, only as supportive agents because they are not that powerful in controlling the inflammation. And cyclophosphamide is a very powerful agent, very toxic when given orally, but sometimes you need to give it as IV pulse therapy, as we shall see very shortly. So when the cornea in the periphery is going on melting, that is the time you have to pulse the patient. The agents of choice would be IV methylprednisolone, or in a more severe patient, IV endoxan or cyclophosphamide. Two things have to be remembered over here. The pulsing is only an acute damage control measure. You have to follow this up with both systemic immunosuppression as well as systemic steroid. Unless the triad of treatment is employed, the medical treatment will fail in Moran's ulcer. And needless to say, these are very powerful medication with a lot of liver and bone marrow toxicity. So we need to consult the internist as to how to administer these treatments. So the surgical treatments that can be used to build a tissue include glue and bandage contact lens, or you can use amniotic membrane, or even you can use a patch graft, which can be a lamella ketroplasty. What you're using is not important. What is more important is to promote the epithelialization. Otherwise, the built-up tissue will again melt to the inflammation. So we've also tried using Tenon's patch graft instead of amniotic membrane, which goes away very quickly in inflamed eyes. And we've been successful with that, and we've published it. And literature shows other supportive agents can be used like nerve growth factor, etc. So what are the tips for surgery in a PUK? PUK by definition is peripheral. So you won't see it right in the center of your operating field. You can use traction sutures to drag the globe down to your area of interest. The limbus should be protected when you're doing large peritomies. Sometimes you need to create a groove. You see the double lamella graft over there. So groove helps you in getting a purchase or grab for the suturing. And sometimes when there is a perforation, you can use temporary glue. The glue may not seal the perforation, but it will keep the globe formed for you to enter the anterior chamber to finish the patch graft. So I'll quickly wrap it up with some case examples demonstrating what we discussed just now. So this is a bilateral Moran's ulcer. You can see the peripheral gutter in both the eyes, and this patient was started on topical and oral steroid therapy. One eye improved, but the second eye, you can see the gutter is progressing, and that eye underwent a peritomy with a cyanoacrylate glue installation and bandage contact lens therapy. A very lightning fast video on how this can be done. So this is a large PUK. So you do a conjunctival peritomy extending well outside the area, exposing the full gutter. Very minimal cautery, you don't want ischemia. The overhanging edge has to be excised for better epithelialization. And then a thin layer is applied of cyanoacrylate glue. You should wait so that it doesn't stick to the bandage contact lens. And after polymerization, the BCL itself is applied. So here you can see the overhanging edge very nicely in this patient that was excised. And then the glue BCL was placed. But since it is a more intense disease, along with topical steroid, azathioprine helped to quieten this eye, as you can see in the second picture. So here is a more severe form of Moran's, where you can see the 1/3 of the cornea is melted and the iris tissue is exposed, needs a patch graft. Doing the graft is not important. Keeping it again from melting is more important. Here is when you pulse the patient. IV methylprednisolone saved the day, followed up with methotrexate therapy. So again, another patient where the perforation had healed when he came to us, and we've done the patch graft with pulse endoxan and oral mycophenolate mofetil. So this is a patient who had melting all around. It looks like a contact lens cornea of rheumatoid arthritis, doesn't it? So this patient underwent an annular patch graft to fortify the tectonic support, but then biologics and mycophenolate mofetil had to be given so that further melting and secondary reactivation do not occur. So it used to be said that medical treatment is not good enough for Moran's, but if you know what to give and when to give and follow it up properly, and in some cases it does work. When you see scleral involvement like this, you may want to rule out Moran's and think of secondary PUK. Lastly, we're all afraid that, you know, the cornea is so thin after the disease. That's not what is important. You see where the arrow is pointing. You could have a wafer-thin cornea in Moran's, but if the epithelialization has happened, then the disease is quiet, and this patient can be saved from toxic immunosuppressing treatment. Lastly, I want to tell you that all that melts may not be Moran's, and we have published this. You see that grid. The first one is a typical Moran's ulcer. The second one, where the lid touches the cornea, you can see a blepharitis-related catarrhal melt. The third one below is a nutritional melt in a small baby. But I want to point your attention to the fourth picture. Somebody's going to talk about it later. Looks a lot like Moran's, doesn't it? But then this is a secondary melt in the peripheral cornea due to pythium keratitis. When infectious peripheral melt is there, how do we distinguish? If infiltration is more than the melt, then it is an infection. Whereas you see the Murans there, the melt is more than the infiltrate, and that may help you to distinguish. I'll close with this last and favorite slide of mine, where you see peripheral infiltrates coalescing just the way the Murans progresses. But then you see a lot of discharge and redness and watering, right? There is not much of, a peripheral congestion like this in Murans ulcer. This is HSV blepharokeratoconjunctivitis. Why should we know the difference? Because in Murans, you want to give steroid. Here, if you give steroid, the viral will flare up, and the treatment is with systematic antiviral therapy. So with that list of differentials, I close my presentation on the management of Murans ulcer. Thank you so very much.
Thank you, Radhika. That was really an extensive, and you covered a lot of ground in Murans. So I would just want to ask you a couple of questions, and then I'll ask our chairpersons to take up some discussion. And I also welcome Dr. Ritu Arora. Good evening, ma'am.
Good evening.
So Radhika, one thing for the general ophthalmologist is that what are the telltale, the 1, 2, 3 signs that you look for when you sign in a case as Murans ulcer?
So as I told you in my presentation, the pain is an outstanding feature in most of the patients. And what you look for is also important. What is not there is also important. So history-wise and examination-wise, there should be no scleral involvement or no, systemic features. And your serological workup needs to be negative, and infection needs to be ruled out. So if these 4 are there, then the patient can be started to be treated as Murans ulcer, and look for the resolution and titrate the treatment beyond that.
Right.
But I think sometimes Murans also has Hep C positive.
So we spoke about that during the presentation.
Okay. Maybe I joined late. Yeah.
When you're talking about that, Dr. Ritu, quite often what happens is Murans, it's not very well based. Okay, it's a concept, but what happens is Murans follows the Hep C or whatever the infection is, because it happens because of molecular mimicry, not that the hepatitis virus itself is causing the peripheral corneal melt. So it triggers an autoimmune reaction. So usually the Hep C is preceded and the Murans follows, and they are not coexisting, as a causative reason.
Right. Right.
Can I make a comment?
Yes, Paras, please.
Yeah, actually, Dr. Radhika highlighted importance of systemic management very well in these cases. Many a times what happens is the comprehensive ophthalmologist would just treat the local condition, and somehow the systemic management is missed out. So we have to look at both the areas very carefully. And especially when you have the Murans is a diagnosis by exclusion. You have excluded all the other causes. And then you decide that probably with all the other clinical features that you are dealing with Murans. It's important to refer these patients, if you are not giving immunosuppression by yourself, to immunologist, and have a good coordination between an immunologist and you to make sure that these patients are simultaneously treated systemically. Otherwise, your local therapy only may not work in severe cases.
So
Absolutely, Paras.
any other panelists? Because if I'm a general practitioner and I have limited resources or ability to sort of treat or follow up, so which are the cases where I can start topical therapy, and where should I definitely start systemic therapy or refer the patient? Because my rheumatologist will not have a complete agreement, because there'll be nothing systemic. Murans by definition is an ocular condition. So my question is that any indications for topical therapy alone?
I think if it's a small one, small gutter, one may start with topical therapy alone, and if it gets easily controlled, then that's fine. But if it is still progressing, despite you giving, topical, maybe mild steroid, lubricants, then that's the time to really refer and, see the cornea specialist and have the systemic treatment added to the whole thing. Or if it is impending perforation, which is going on, that's the time to refer.
So a word of
At times
caution
there
over there. Sorry.
At times there are cases where people have done just a TABCL or multi-layered AMG for those patients with peritomy and all. And the first episode is probably controlled, but many a times these patients present with recurrence and with a larger area of infiltration and corneal melt. So these are the cases where one has to be very careful in treating them both ways, systemic as well as local management.
Yeah.
So if there's one thing people need to focus on, as a message, I would like to say it is the importance of the epithelialization.
Yeah.
So whenever the gutter goes more than 30% of the cornea and it is not epithelialized, I think it is time to, build the tectonic support along with the immunosuppression, because that is the point where your steroid may actually help in melting the cornea faster than controlling the inflammation. People worry about the gutter, worry about the pain, worry about the immunosuppression, but the emphasis should be on epithelialization. You could have a wafer thin cornea which is epithelialized, which is not a cause of concern, whereas even a 10% melt which is refusing to epithelialize may lead to actually a perforation.
So then what I understood is that if I have a patient with a mild disease, as in has a unilateral 2-3 cloacas of peripheral corneal ulceration with the overhanging edge, so that in a older patient, perhaps elderly patient, and chronic history and has pain also, and I look for the differentials that you mentioned, which one very important clue was look for if there's more infiltrate rather than thinning. So that could be infection. So I look for those differentials. There is no scleral involvement. So I can sort of consider this as a case of Morin's ulcer and take care of the thinning first. So maybe by cyanoacrylate glue application, as you've shown in the video, and then start the patient on topical steroids. And this is the initial therapy. And if the patient has recurrences and so on, then I have to either refer the patient or start the patient on systemic therapy, which should include immunosuppressant therapy. Great.
Absolutely.
Thank you so much, Dr. Radhika. I hope that that everybody could pick up some tips and have some guidelines towards how to manage these cases. Feel free to stay back till the end. I know that you have another commitment, but feel free to stay in.
I'll be in and out, sure. Thank you.
So we move on to the second equally interesting topic by an equally interesting speaker. So my next speaker is Professor Ritu Arora. As probably all of you know, that she was professor and head at GNEC in New Delhi, and now she's in Shroff Eye Center in New Delhi in private practice. Over to you, ma'am. And her interesting topic is about cases, how she's managed in rheumatoid arthritis.
Yeah, so this is a one single case. Can you hear me?
Yes, we can. Yes, yes.
Yeah. So I am just focusing at the moment, though one sees a lot of PUK in RA, but this is one very peculiar case which we encountered of rheumatoid arthritis, and I'll tell about the salient features in this case and what all the lessons which we learned. So, this is how I came into a picture. If you can see, this patient was, I was called in it was a cross referral in December 2024 of this case, which had undergone vitreoretinal surgery. And you can see here that there is a large peripheral corneal melt with iris prolapse. And in another area where there was present a corneal thinning, and there was present a silicone oil bubble in the anterior chamber with the cataract. So the surgeon had called me up suddenly saying, while the patient was on the follow-up, that I do not know, but I see something funny. That's the way I was.
I think you're not in full screen. At least on my screen, it's not in full screen.
I
Yes,
am
ma'am.
full screen.
On your screen,
No.
you are in full screen?
No, ma'am, you have to get into a presentation mode.
I am actually in the present. In my
Okay.
screen, I am getting full screen.
Can you please help? I think it's not, for us, it's not in presentation mode.
Yes, ma'am.
It's not the presentation mode. 1 minute.
Can you help?
I'll stop share and I'll reshare again.
Yes, ma'am. Yeah.
Just a minute. Yeah, maybe it was originally like that. And now?
Yeah,
How is it now?
we're just waiting for it to come on.
Yeah, from my side, it is coming. No? Okay, 1 minute.
Yeah, good. Can I help?
Yes, please. Yes.
Can you, what are you getting on the screen?
I am getting my presentation on the screen.
You need to press the share button on the Zoom window.
Yeah, that's what I had done earlier. 1 minute.
We can try that again.
I'm just trying that again. Just a minute. But if I'm trying the share button over here,
When you press the share button, it will give you a pop-up.
Yeah. That's what I did earlier. 1 minute.
Can you just try it again?
Just a minute.
Yeah.
I am on the Zoom screen right now.
6 o'clock, there will be a share button.
Yes, there is a share button. Maybe I had opened my presentation
No,
earlier.
let's do that again. Just click the share button again.
Okay, just a minute, please. Yes, I'm click the share button.
There will be a pop-up on the left-hand side. You will have entire screen. Just click the, just select the
It says
entire
share
screen.
settings.
No, just the share button. You will have a
No,
share button.
when I do the share, it says share settings. Yeah. Then I am coming to my main presentation.
No, if they're just giving you share setting, you are on Mac, I believe.
Yes, I'm on Mac.
You will have to give permission in your Mac going into security and privacy, and you have to allow Zoom to record the screen. In privacy and settings.
So I can't share right now, right?
We can skip the sequence in case you want to.
Or why don't we
You
continue
can
like
mail it
that?
to you can mail it to one of us, and we can have the next presentation, Somshila, and we can share it for you. Would you like us to do that?
No, now.
Perfect.
What is it coming?
Perfect.
It is coming?
Yes, if we then
Yes,
make it
yes,
into
yes.
slideshow mode once, please.
Yeah, I'll go to a slideshow. Now,
Yes. I think that's fine. I think
that's fine?
Yeah. Is that the first slide though?
Yeah, this is the first slide.
Okay. All right,
Yeah.
ma'am. Please
Yeah.
go ahead.
Yeah, this is the first slide. So this is how the eye came into the picture, that there was present peripheral big large iris prolapse, and at 2 o'clock there was present a small it felt like as if there was a small iris and there was a considerable thinning of the cornea. So when I just went back and I saw the patient, this was actually a 62-year-old lady who had 6 months back had undergone a VR surgery, vitrectomy, band buckle, LIO, silicone oil injection in the left eye for retinal detachment. She was on constant follow-up and while she was on the follow-up for silicone oil removal, and I mean, this was the last setting when she was to be fixed up for silicone oil removal and phaco with IOL. She presented with superior corneal melts with iris prolapse by 10 o'clock and corneal thinning, minimal iridocorneal touch at 2 o'clock. There was present a silicone oil in the anterior chamber with advanced grade 3 cataract. Now, the question was what to do next. This was the picture which the surgeon shared with me, that in May 24, the patient had presented like this. You can see there's retinal detachment. OCT showed retinal detachment. 1 month post-op, retina was very well settled. And then when I further, and this is what is telling the concise, that there was no history of trauma, pain, redness to the patient. Further, when I probed the history in December 24, patient said that she was a known case of rheumatoid arthritis, was in finger joint abnormalities. I can say that it was probably all ignored in the first sitting. And she said that she was a known case of rheumatoid arthritis and was on medication for RA. But during COVID, as multiple immunologist consultations had stopped, she had stopped taking all the medication. At that time, we sought a fresh rheumatologist opinion, and she was started on oral disease-modifying agents. Pulse milligram IV methylpred was given for 3 days. And she was planned for a corneal patch graft, two grafts. One was a full thickness, one was a lamellar in the left eye. So this, I will just be showing you the video as to how we went ahead and did it. So you can see we do not know for how long this iris has been prolapsed because it was absolutely silent. Patient knew nothing about it. So I am having a lot of problem in separating this iris from the overlying cornea. There is present a silicone oil, you can see in the AC, and it is just coming out from this perforation. I didn't try to reposit the iris. Instead, I created multiple iridotomies in the iris, which had prolapsed. I didn't want to excise it. And after making multiple iridotomies, I could see the silicone oil was even coming out from the periphery part through the zonules. And there was present a cataract. With great difficulty, I finally managed to separate these iridocorneal adhesions. And after making sure that this iris is separated, and by that time, a lot of hypotony had taken place. This defect was 3 millimeters. And areas where I could not separate, I even snipped the iris from the overlying cornea. And then I made 2 corneal patch grafts, buttons, as Dr. Radhika has already shown. It doesn't matter whatever you use. So this was, one was a full thickness circular 3 millimeter corneal graft, which I placed over this full thickness defect. And in the other area, I realized it was a partial thickness. So I just did a lamellar corneal surgery over there. Over here, of course, in this place, I put 12 sutures, 10-0 sutures. It was great difficulty because a lot of hypotony had taken place. I did a lamellar graft in this area. I just put 4 sutures, and remaining cornea, I left it with fibrin glue so that I could close the globe. I had a lot of problem forming the anterior chamber at the end because whatever fluid or whatever air I was putting was always going behind. And then after that, how do I go to the next? Yeah. This was the first day post patch graft. You can see there are corneal folds. The patch grafts are in position, and there is present severe hypotony, and there is present air bubble in the anterior chamber. So the major point I want to suggest here is that the corneal melts in rheumatoid arthritis may be silent. They're often peripheral, not associated with any pain, redness, watering. They usually have a coexistent dry eye. They may be related to topical NSAID use, especially because this patient had undergone a retinal surgery. And they may be seen with post-cataract surgery. So any cataract surgery in rheumatoid arthritis, I'm always very cautious. And they may be the first presenting feature of the disease. Options available in such conditions are here. When it is less than 2 millimeter, use a TA with BCL. We may use a Tenon's graft or a corneal patch graft or an amniotic membrane graft. Sometimes conjunctival graft has also been used. Large corneal perforation, use a tectonic PK. But the mainstay is that supplementary steroids and disease-modifying agents are a must. The surgical challenges which I faced here was large iris prolapse, not possible to reposit the prolapsed iris, so better to avoid. You may do multiple small peripheral iridotomies. Separation of the iris from the cornea as adhesions are strong may be dense. Hypotony, silicon oil interference, and AC formation is challenging. This is the picture which I want to show, that post-patch graft at 1 week. At 14 weeks, the patient underwent final suture removal, but she always wanted vision. So this is at 14 weeks, the sutures had been removed, and there are present 2 successful corneal grafts over here. And then after 4 months, you can see when we plan the patient for cataract surgery, the area where there was present an iris prolapse, this is a full thickness patch graft, and there is iris is having adhesion here, while in the other area where there was a lamellar graft, the iris is quite separated. And this is, we did a pre-op specular, which was about 1200. And this is what I wanted to show you, the cataract surgery in this patient. Since the pupil was not dilating, we put these 4 marks for the iris retractus. There was a problem as to know that which site to be used for site port, and because they were present iris adhesions. So iris was not getting separated. It is here when I used my microvanas to separate the iris from the patch graft. And the iris is very floppy, and you keep getting the tags again and again when you put your phacoprobe. So this is where when we put the iris, we didn't want to put the Malaguin ring here because the visibility was not very clear. Went ahead with an iris prolapse because I didn't know that what the site would look like at that 10 o'clock area. So after putting the iris repositors, we stained the capsule with trypan blue, made a proper rhexis. It was a grade, almost going on to grade 4 cataract. It had progressed. And after that, with multiple areas, we chopped the nucleus. But at this time also, you can see that silicon oil kept coming in the anterior chamber. We were rotating, and I wasn't too sure at that time whether the patch graft which we have done are going to give us enough integrity for the phaco to be done. So those were the questions in our mind. But somehow the patch graft sustained, And you can see it was a rocky heart cataract by this time. And and it's a vitrectomized eye, mind you, and retina is attached. So this patient in one sitting underwent phaco with silicone viscoelastic. There was a copious viscoelastic was injected again and again, but the major problem was coming because of floppy iris. Because of floppy iris and the iris tags, and there is always a risk of the iris getting dragged into the phacoprobe. So after these multiple small pieces of the cataract are made, then they were aspirated. There was always a possibility in such cases when there are peripheral grafts that there may be a zonular dialysis, and the bag integrity is always questionable. So we were ready with our capsule tension rings also over here, but somehow the bag did not give us any problem, and we could successfully take out the cataract. And since the count was on the lower side, so that was a thing. So a lot of time we kept putting. You can see that here how the iris is coming again and again, and so it had to be snipped. And after that, we put in the IOL. We put in the IOL in the bag, and after that, once the retractors are out, all the incision, this is just the bimanual IA. You can see there is silicone oil present in the silicone oil is again coming into the anterior chamber, and the wound, all the wound was sutured. 3 sutures were placed on the main wound and on the side port. So this is how we could do the main surgery. So the challenges were pupil dilatation, where we used retractor or expanders. The site of the side port was again a challenge and the entry of instruments, because iris adhesions, irregular anterior chamber, it had to be snipped. Iris tags in the phacotips, chances of missing zonules, and integrity of corneal perforation was always playing on our mind. Silicone oil in AC, and low count and dry eye. So this is what I just want to show, that this is the patient 1 week post phaco, and finally at 4 months after surgery, you can see patient regained a vision of 624. The peripheral perforations are nicely patched, and patient has a stable IOL and almost circular pupil. This is the ASOCT, which is showing that there is no adhesion to the graft. AC is very well formed, and the retina is attached. This is the repeat retina. So the lesson which at least I learned, that the proper history is very, very important. And in rheumatoid arthritis patient, any surgery has to be dealt with caution, preferably under the cover of oral steroids. Need to manage coexisting dry eye, may need, sometimes I've done tarsorrhaphy and then gone and did cataract surgery also. Need punctal plugs, avoid topical NSAIDs. And this is just the review of literature, where we found that some cases are reported after cataract surgery, managed with patch graft. And this is another one from LVPI, where they have used an amniotic membrane to seal the graft. And this is what we published, this case in AJO. And there's another case which I lately got, where same kind of a case, but there the topical diclofenac was used in the case of RA. So the take-home message, I just want to say that a sequential management of moderate corneal perforation with patch grafts, followed by careful cataract surgery and aid of oral immunomodulators, gives successful results in rheumatoid arthritis. Thank you very much.
That was an excellent case, so well managed, and the surgical outcome was so good, ma'am. So hats off to you for that. And many, many tips that we learned. So I'd just like to sort of dial back a little bit and go to first to the clinical part, and then maybe the next would be the surgical part. So in the clinical part, as you have highlighted so well and so candidly, that the history was completely missed. But this has always been a blind spot for us, where we look at the eye, and oftentimes we either may not ask history, or the other problem is that the patient does not think it relevant to provide that systemic history, because that's going on systemically. So they think that it doesn't affect the eye, and they often don't tell us that history till we suspect it. So the onus is on us, that when we see a patient with these more than one area of corneal melt, And maybe in your case, you had the iris just plugging it in one area where you did the lamellar, and then you had the iris prolapsing where you had to do the full thickness. So this is literally crying that this is a patient with maybe most likely to be RA, this kind of clinical picture. So those today who are watching the webinar or later on who look at it, if you go through the video and you see the presentation of the patient, the clinical pictures, so that's exactly how most patients with RA, especially the advanced RA, they come to us. So when we have patients coming with such severe disease, it means that the RA also is very advanced actually. So you don't have somebody with barely any features of rheumatoid arthritis, but having this kind of condition. That doesn't happen. So in rheumatoid arthritis, it's not a silent disease. When it affects the eye, it's shouting out to you that it is rheumatoid arthritis. So thanks for bringing that up. About this, I'll request our chairs and panelists to discuss a little bit further, especially about the surgical part.
I just have one thing to add, and hello, ma'am. What was the other eye status? Because I mean, RA to diagnose the one of the most important clue I'd usually take is from the other eye, ma'am.
Other eye was absolutely normal. Rather, she underwent phaco after this. No, here, what I'm trying to say is that patient had already undergone a retinal surgery. And within 5 months, while patient was awaiting the silicone oil removal and cataract, she landed up with this. So I feel that the surgery per se acted as a trigger for the patient to go into corneal perforation.
Maybe post-operative use of NSAIDs also, it is
Absolutely.
No NSAIDs were given to this patient.
Okay.
Yeah, that's what I checked with them. No NSAIDs were given to this patient.
RA can present bilaterally very asymmetrical. I've also seen cases like that. And typically, these patients would have one eye very, very bad, and the other eye is just starting. So we'll have to keep a very careful watch on this patient because the other eye also can slowly start going downhill unless we've kept the patient on adequate.
Yes, now the patient is on systemic steroids, though tapering. She's doing very well. She meanwhile has undergone phaco for the other eye also, absolutely uncomplicated, you know. So, whenever I have done earlier, because once or twice even I have seen patients who have presented just with perforations, were not known cases of RA.
Right.
And, you know, they had undergone cataract surgeries outside and they presented like this to me. So that's the time when one suspected that they had RA. You know, I feel somehow the surgery acts as a trigger, with or without NSAIDs.
And there are times when ophthalmologists are able to diagnose the patient for
what I'm saying. This may be the first presentation.
We've been able to do it, yeah.
I saw Dr. Namrata was about to ask something. Namrata, are you there? So coming to the surgical part, yes, Namrata.
Yes, ma'am. I'm very much there. Very interesting case, ma'am. I was not gonna ask anything. I think some confusion. So.
All right. The surgical part, of course, Dr. Ritu, we all know what an accomplished surgeon you are, but this is almost like pulling that proverbial rabbit out of the magician's hat, because I never expected such a great outcome for this patient. I think patient is also very lucky. So
she's happy.
Yeah, we learned about the surgical tips from you. Maybe one thing that I've learned because of the uveitic cataracts or these kind of cataracts is that I always touch the posterior synechiae or the anterior synechiae. If they're not affecting my view, then I just leave them, especially the peripheral anterior synechiae. I just leave them till the very end, and then I'll address that. So that the same problem that you had, otherwise they'll keep flopping and coming in your surgical field. But
yes,
but otherwise it was flawless surgery. And in most of our cases, as you know, that the cornea has adequate tectonicity for us to do a phaco. Maybe if we want, we could reduce the bottle height just to sort of decrease the volume and the pressure that goes on inside the eye. But otherwise,
yes, that was done. I forgot to add that. Yes. Yeah.
And you saw the clouding that happened when we were using the phaco. That is because of the silicone oil initially. And unknowingly, the silicone oil keeps coming into the eye, and we're all the time thinking about the corneal endothelium and how it's going to be affected with the silicone oil.
Yes. Here, I was always fearing that there will be an underlying zonular loss, especially because when there's an iris prolapse, usually underlying zonules are always missing. But somehow it wasn't there.
So this patient also is being continued on lubricating eye drops as well
Yes,
as
now on lubricating and oral steroids, tapering dose, low dose steroids, and methotrexate.
But
So
does the patient have a significant dry eye? Have we done a Shermer's? Do we know
yes,
that?
Shermer is about 5.
Okay. So
Shermer
this
is 5.
patient, that's an important aspect that we must make sure that the medical therapy goes on. And as you already put in your presentation, that either punctal plugs or punctal cautery, if maybe if you start seeing a little evidence of dry eye, for example, SPKs or filaments or anything like that, then you should go in very. I would probably, knowing that it's RA, I might even just do punctal cautery because I have a surgical opportunity when I did the cataract. I would probably just combine it with punctal
Good
cautery.
idea. Good idea. Good idea.
Any other comments from
I am little foxed about how good are the results of Teenan's patch graft in such cases.
Extremely good. So at least for the lamellar part that you had, I think most of us now we would resort to Teenan's patch graft. Maybe for the full thickness, it looked like really tough, but still we would try sort of a multi-layer, the Teenan's patch graft, maybe put amniotic membrane. So still, avoid cornea and try anything else. And cornea is always a last resort. So now I think most of us in practice have switched to using cornea only when there is nothing else that will work, like a large graft or a therapeutic graft or a large perforation. I don't know if Manisha, Paras, what is your experience?
Yeah, I would agree to
the
that.
partial
Most of the
thickness, even
sorry.
I prefer. Sorry. In partial thickness, even I prefer Tendon patch graft now, vis-a-vis the bigger patch graft. But the other lesion with the iris out, patch graft remains the only options. But the other one, we could have done Tendon's patch graft.
But this is good enough. I mean,
once you have a cornea available,
yes, that's right.
Yeah. And ma'am, even in this size of, it was a fantastic surgery, I would say. You handled that so very well. But even this size of perforation can do very well with Teenan's patch graft.
This large?
So even
I have
the
no.
full
I have
yeah,
no.
even if it is a full thickness, because even up to 3, one of the, one of the paper from Arvind, they have used Teenan's patch graft for even as large as, 5 to 6 millimeter corneal perforations, and they had very good results. So similarly, but this was hardly 3 millimeters. So probably, one could have done even a Teenan's patch graft.
Okay.
But separating the iris was very tricky, maybe probably making another side port and going from that area with a syneculitis would have also been helpful in those areas.
Actually, because one didn't know for how long this iris had been prolapsed.
Yes, very true.
That also we didn't know.
These kind of cases, if I'm able to tectonically stabilize the eye, I can live with adherent glaucoma. I have no problems with adherent glaucoma for these patients. So just, of course, look for secondary glaucoma. But that to me is still a good result as opposed to not being able to do it.
Yeah.
Yes.
Thank you.
That was an excellent case, and that gives us an absolute way to segue into the first presentation for today from our young faculty. So Dr. Preeti Rao is going to present her case. Preeti is from INS Ashwini. She's a resident there, Preeti. Is that right? Yes, and I got a little confused because your name label says Priyank Rao. Then I even checked that have you got your name wrong, but you are Preeti after all. Yes. And Dr. Fahim is going to discuss this case. So Preeti, you have about 8-ish minutes. So we have adequate discussion time as well. Over to you.
Thank you.
I think, yeah, all right, good.
So my patient is a 68-year-old housewife resident of Maharashtra who presented to us with chief complaints of diminution of vision in her right eye of 1 month duration. The patient was apparently asymptomatic 1 month back when she developed sudden onset painful diminution of vision in her right eye following a fingernail trauma while playing with her grandchild. It was associated with redness, watering, photophobia, and foreign body sensation. She was prescribed steroid and antibiotic eye drops for 2 weeks by a local practitioner. However, there was no improvement in her symptoms, and in view of corneal thinning, she was referred by the local practitioner to the center for further management. There was no history of contact lens use, and there was no history of any similar episodes in the past. Coming to the past ocular history, she had undergone cataract surgery with PCIOL implantation in both eyes 3 years back. Post cataract surgery, she had complete visual recovery. There was no history of any long term use of eye drops, and there was no history of any other ocular procedures. She is a known case of hypertension for the past 10 years and is on regular medication. She gives history of joint pains 2 years back, for which she was consulted by a physician, and she took oral medication for the same for 6 months and then abruptly discontinued. Coming to her personal history, she consumes a mixed diet, has normal sleep and appetite, normal bladder and bowel habits. There was no history of any addictions or any known drug allergies. Her family history was not significant. On examination, the patient was conscious and oriented. She was moderately built and was well nourished. She was afebrile and her vitals were stable. The systemic examination was within normal limits. Coming to the ocular examination, her unaided distal visual acuity in right eye was 6/60 with no further improvement with pinhole, and in left eye it was 6/9 improving to 6/6 with pinhole. There was no RAPD, the head posture was normal, and the extraocular movements were full free in all directions of these. Coming to the anterior segment examination for right eye, the eyelids and adnexa were normal. The conjunctiva was congested, and there was circumcorneal congestion, more prominent superiorly. In the cornea, there was a crescent-shaped ulcer superiorly extending from 11 to 2 o'clock position. There was an epithelial defect measuring 5.5 into 1.5 mm overlying deep stromal infiltrate. Focal stromal thinning with 2 into 1.2 mm perforation was present. Cornea was hazy due to stromal edema with Descemet membrane pores. The Seidel test was positive and the corneal sensations were preserved. The anterior chamber was shallow with 2+ cells and 1+ sphere. The iris was normal in color and pattern. The pupil was central, circular, and reacting to light. There was a posterior chamber single-piece monofocal intraocular lens in situ. And for the fundus examination, the media was hazy. The optic disc was normal in size, shape, color, and margin with a cup disc ratio of 0.3:1, and the NRR was healthy. Vessels were rising from the center of the disc and were dichotomously branching. They were normal in course and caliber with an AVR of 2:3, and the foveal reflex was present. This is a representative image of a similar case, courtesy Dr. Lankashri Harsha. Here we can the images for our patient were unfortunately not available. Here we can see a corneal ulcer located superiorly extending from 10 to 2 o'clock position with a corneal perforation. There is diffuse corneal haze and Descemet membrane pores can be seen. The left eye examination was essentially within normal limits. So our diagnosis for this patient was peripheral ulcerative keratitis right eye and pseudophakia both eyes. So to sum it up, our patient is a 68-year-old female housewife by occupation who presented to us with painful diminution of vision in her right eye following a trivial fingernail trauma, and these were her key ocular findings. So the first thing in our management that we did corneal scrapings, and we sent them for trial stain and KOH mount, which were negative for bacteria and fungal hyphae. We also sent the corneal scrapings for culture, blood agar, chocolate agar, and subdural dextrose agar, in which there was no growth at 48 hours and on 7 days. Since all the microbiological studies were negative, this supports a diagnosis of non-infectious immune-mediated etiology of PUK. We also sent blood investigations for autoimmune diseases and systemic infections. And in our patient, the rheumatoid factor was elevated. The anti-CCP antibodies were strongly positive, as well as ESR and CRP were elevated. So this confirmed our diagnosis of seropositive rheumatoid arthritis-associated peripheral ulcerative keratitis. Coming to the management for this patient, since the patient presented with a 2 mm perforation, she was immediately taken to OT for tectonic intervention with cyanoacrylate glue and BCA. This is the intraoperative image of a similar patient. Here we can see cyanoacrylate glue applied superiorly along with conjunctival resection, perilimbal conjunctival resection, courtesy Dr. Lankashri Harsha. Immediately following the surgery, we started the patient on hourly preservative-free lubricants. This was essentially done to wash out and dilute the inflammatory mediators and proteolytic enzymes. Topical cyclosporine 0.1% BD was started. Cyclosporine downregulates the local T-cell mediated tissue destruction. We also started the patient on doxycycline 100 mg BD and vitamin C 1 gram per day. Doxycycline antagonizes the local collagenolysis by irreversible inhibition of matrix metalloproteinases, and vitamin C facilitates collagen and stromal regeneration. We also started the patient on fourth generation fluoroquinolone antibiotic, moxifloxacin 0.5%, to prevent any superadded infection. Along with this, topical cycloplegic homatropine was given for pain relief. The cornerstone of management of PK associated with an underlying systemic autoimmune disease is immunosuppression. And since our patient presented with severe corneal thinning and perforation, a single shot of IV prednisolone, 1 gram per day, was given for rapid suppression of the acute inflammatory cascade. We also started the patient on oral prednisolone at a dose of 1 mg per kg per day. And since our patient was positive for RA factor and anti-CCP antibodies, a rheumatologic consult was sought and the patient was started on tablet methotrexate 10 mg once a week. The patient responded very well to the treatment, and by day 4 post-admission, the ocular pain had completely relieved. By week 3, the eye was quiet and the cyanoacrylate glue had stabilized. By month 2, the cyanoacrylate glue had spontaneously dislodged. There was a leukomatous scar in the superior cornea. There was no reperforation and the structural integrity was maintained. And the visual acuity of the patient had improved to 6/12. And the patient was stable on tablet methotrexate only. So the take-home message is the peripheral corneal ulcer is just the tip of the iceberg, as they are mostly associated with an underlying systemic disorder. So in these cases, an extensive systemic evaluation is very important for management. Severe corneal thinning, dysmetocele, perforation, when present, are a surgical emergency and should be managed accordingly. For small perforations less than 3 mm, cyanoacrylate glue plus BCL are a good management option. All microbiological workup must be negative before diagnosing any patient as immune-mediated POK. And if we are labeling a case as immune-mediated POK, a rheumatological consult should be taken. And finally, immunosuppressives and biologicals not only save vision, but also save lives. Thank you.
Very well presented, Preeti, and excellent case for demonstration of the topic. Dr. Fahim, you have your comments on this case?
Good evening, ma'am. First of all, I would like to thank AIOS and Soila ma'am, Triage sir, for giving us this opportunity to present this case. This patient, she had presented to us about 1.5, 2 years back. And when she presented to us, she already had been symptomatic for about 1.5, 2 months. And she had already consulted a local practitioner and had taken some treatment from there. And when she presented to us, she already had a perforation and there was severe corneal thinning, as was explained in the examination by Dr. Preeti. And when she presented to us, because of the perforation and the size of the perforation, which was just about 2 millimeters in size. So we did a glue plus BCL in that patient with conjunctival resection and started her on immunosuppressive agents. And along with consultation with the rheumatologist, we started her on methotrexate also, and she responded very well to treatment. So what I would like all the residents or young ophthalmologists who are watching this presentation is that whenever a patient presents with a peripheral ulcerative keratitis, the first step to do in such patients is do a corneal scraping. Send it for gram stain and QH. Once the results of those tests are available, usually within half an hour to 20 minutes. So once those are negative, and at the same time also send it for cultures. And once those are negative, you're almost sure that it is not an infectious case, and you can confidently start those patients on steroids as well as immunosuppressives. Simultaneously, also take the blood samples of the patient and send them for a complete autoimmune workup. And then as mentioned by Dr. Preeti, the cornerstone in cases of these peripheral ulcerative keratitis with underlying autoimmune disorders is the immunosuppressive treatment. We start the patient on steroids. And since in our case, the patient already had presented to us with severe corneal along with a perforation, we gave her a shot of immunosuppressive with IV methylprednisolone. Also, along with that, we started her on oral prednisolone at tapering dose. And since we are in a tertiary care hospital with an in-house rheumatologist present, that is advantage available to us. We also consulted with the rheumatologist. Along with his consultation, the patient was also started on, based on his opinion, the patient was started on methotrexate. And with the combination of all this treatment, the patient responded very well. And at the end of 2 months, we had almost completely tapered off oral steroids, and she was on maintenance dose with just methotrexate, and she was responding very well to treatment. So a multidisciplinary approach, along with a consultation with rheumatologist, a good thorough workup of the patient with good microbiological workup, and immediate immunosuppressive treatment. Those are the three most important things that should be remembered by general ophthalmologists whenever they are treating with, whenever they are encountering a patient with peripheral ulcerative keratitis, and whenever they see signs of thinning, I think it is better to refer to a cornea specialist so that the patient doesn't develop any perforation, or in case any intervention is required, it can be taken in that way. A couple of things that I've observed, as was mentioned by Ritu Arora ma'am also, that some of the cases getting triggered after cataract surgery. In fact, the image that we had used in our case, the one which had taken from Dr. Lanka, that patient was also, she was asymptomatic preoperatively. She had undergone a cataract surgery, which was a routine cataract surgery, but immediately after cataract surgery, she developed those symptoms. So probably a thorough preoperative history, doing a dry eye workup, thorough dry eye workup, and a systemic examination to rule out any, if she has any joint deformities, any systemic, any rashes, to rule out systemic involvement. That should also be incorporated before a preoperative workup, even in general ophthalmology before doing a cataract surgery in those cases. Thank you.
Any comments from Dr. Ritu?
Sorry, she's presented it very well, and Dr. Fahim has discussed it very well. So here we come to the conclusion that this patient had rheumatoid arthritis, or
Yes,
what
yes,
the underlying cause?
Yes, rheumatoid arthritis was an underlying cause which was found after we did those tests. She was RA factor positive and anti-CCP positive.
Yeah. But the problem sometimes comes when we find nothing positive in these patients.
Right, right.
Sometimes even that happens. So that
Right,
time one is in a fix, and whether to give steroids or immunosuppressives, that's where I've been tied up in these cases. Yeah,
Right.
otherwise well managed case.
Thank you, thank you.
Thanks, Dr. Fahim. Are there any comments from the other panelists about this case? Saujanya, do you have any comments about this case?
Hi, Doctor. Well-managed case. Same. My question was, when if the RA factor is negative, then the question how to go about it, these cases.
But you know that even if RA factor is negative, so the rheumatologist would combine with anti-CCP antibody. And also that sometimes you can have patients with RA where the RA factor is negative. So they also don't rely only on RA factor, but they see the symptomatology and the other clinical features of the patient systemically. So we can still label a patient. So RA factor can be positive without having RA also.
So they are seronegative rheumatoid arthritis, but sometimes, I've seen that they have those hand deformities and other things that rheumatologist says there is no active RA.
Right.
But we see a lot of ocular problems, and they are not very willing to put them on any steroids or immunosuppressives. But then we have to insist and say that such kind of a case needs it. They say it's a burnt out RA. I don't know if you've seen those kind of cases.
No, we have for sure, but it depends on what is the ocular ocular disease.
A puff or something, So that time also, they may not have active RA.
True, but if it is dry, if it's for dry eye, that we are asking. So in dry eye already, in Sjogren's syndrome, in other words, Sjogren's syndrome, then there is no point how much of immunosuppression we give. There won't be reversal of Sjogren's syndrome. So in that way, they are correct that there's no point. But if you have the vasculitis active part where we have PUK, scleritis, and so in those patients, obviously we have to convince them that this is an extraarticular manifestation of RA, and it has to be treated with, and it's a sight threatening, so it is a very severe problem. And now I think most rheumatologists are onboarded that
Yes.
they are. So extraarticular RA is very well known, and if the organ involved is the eye, then we have to push them though, that they have
Yes, that's what I was coming to.
Yes, because it is because they don't have control over the follow-up or over the clinical signs. So if it's systemic, then they are in complete control. But here they have to rely on us, and we have to tell them that it's better or worse, or So I would guess that anybody would be reluctant for that reason. So we have to give all the toxic medication and everything. We enjoy that benefit thanks to them, and then we have to drive them to do that. So you need a very good collaboration.
Absolutely.
Absolutely.
Ma'am, on that note,
another small point, if I may make, is also, like I think Dr. Fahim mentioned it in the passing, to look for dry eye, because if we focus on the PUK and the eye is anyway inflamed and watering, unless we get a basal tear secretion measured, we won't know the dry eye. Sometimes that may be the culprit in preventing the PUK from healing, one of the additional factors. As an extension of that, in these patients who are seropositive, we see central ulceration. Then rather than immune, it's because of the dry eye. It's a rare entity, but has to be kept in mind when you see an immune patient with a central ulcer. Then it's probably the dry eye that is the culprit.
Very true. So great presentation, Preeti. Thank you for that. We move on to the next.
On that note, I just wanted to
request
and put forth one thought, because as you rightly mentioned, these days we have primed our rheumatologist colleagues, but still ophthalmic manifestations are not included in rheumatological guidelines and literature. So can we as a whole, like body of ophthalmologists, come up with these suggestions for rheumatology body, so that all these things eventually gets included into literature and guidelines?
Very important, very excellent point, Namrata. But beyond the scope of today's webinar, but we will work on that when we get together. Excellent point.
Just a word of caution, I just want to say that today only I saw one case who had Sjogren's. I mean, I'm just going a little out. And she had right eye. She had seen me 2 years back, right eye impending perforation. Somebody did an amniotic membrane. Then further, the person did a Tenon's patch graft in that eye. At that time, with her pros lens, she was 6'9", but with all those thinnings. But today, when she came, she was PR inaccurate in that eye. And the left eye, she was wearing a scleral contact lens. And she said suddenly she has developed blurring. And another point I just want to say, the patient was put on topical steroids, and she had come with severe glaucoma today. So we also have to keep that also under thing. Her pressure was 48. So it was uncontrolled with other things. Just a word of caution, that's all.
Okay. These are all tip of the iceberg cases. So just like Preeti presented one tip of the iceberg with the case of RA, we move on to the other tip of the iceberg kind of case. And Dr. Monica is going to present to us a very interesting case. I've heard her presentation before, so I asked her to be part of this presentation. Monica, over to you.
Yes.
So Dr. Monica is a fellow at LV Prasad Institute in Vijayawada, and she's training to be as good a cornea specialist as Dr. Arora.
Good evening, everyone. Are my slides visible?
Yes, they are.
Good evening, everyone. I'm Monica, and the moderator for today's session will be Dr. Saujanya Uyuru. I would like to present a case that demonstrates how vision-threatening ocular inflammation can be the first clue to a systemic disease. Titled The Tip of the Iceberg, Necrotizing Scleritis Revealing Granulomatosis with Polyangiitis. Objectives for today's presentation are to review the systemic manifestations associated with immune-mediated scleritis and to discuss the management of immune-mediated scleritis, including the role of corticosteroids, immunomodulatory therapy, biologic agents, and need for a multidisciplinary approach to preserve vision and to control the systemic disease. Coming to the case details, a 45-year-old female homemaker from Anakapalli, Andhra Pradesh, presented to our clinic with complaints of redness, watering, pain, and diminished vision in left eye over 2 months. The patient gave history of intermittent redness in her left eye over 8 months. This became persistent over 2 months. Apart from her eyes, she had arthralgia, including bilateral knees, wrist, and pains in her small joints over 2 years. There was no history of ocular trauma. There was no history of diabetes mellitus or hypertension. On examination, patient's head posture was erect, had orthotropic eye alignment with facial symmetry maintained. Best corrected vision in her right eye was 20/20 and in left eye it was 20/25 parts. Both eyes had N6 near vision with plus 1.5 diopter correction. The eyelids in both eyes were flat. Right eye anterior segment findings were unremarkable, whereas left eye anterior segment findings I shall be explaining in further slides. Both eyes had clear lens, and on fundus examination, both eyes had a cup disc ratio of 0.3 with retina attached. Intraocular pressure measured with Goldman ablation tonometry was 12 and 14 millimeters of mercury in right and left eye respectively. The slit lamp examination of left eye revealed diffuse conjunctival congestion with dilated and engorged blood vessels seen over temporal bulbar conjunctiva. Along with that, there were peripheral corneal stromal infiltrates from 3 to 4 o'clock position adjacent to the limbus with 80% stromal thinning and overlying epidefect. Patient was subjected to corneal scraping, where on smear examination on grams and kevoid staining, no organism was seen, and subsequently a cyanoacrylate glue and bandage contact lens was placed, considering the stromal thinning. Provisional diagnosis at this point was both a presbyopia and left eye peripheral ulcerative keratitis. Some of the common differentials that can clinically mimic PUK are Moran's ulcer, which is idiopathic autoimmune peripheral corneal ulceration. It typically presents with pain that is disproportionate to the size of the lesion, and overhanging leading edge and superficial vascularization extending up to the ulcer bed. Unlike immune-mediated PUK, Moran's ulcer is not associated with scleritis or any underlying systemic autoimmune disease, making it an important distinguishing diagnosis. Our second differential can be herpes simplex virus or HSV marginal keratitis. It usually presents as a crescent-shaped peripheral corneal infiltrate, often without a lucid interval between the limbus and the lesion, along with both superficial and deep corneal vascularization. Moving on to third differential, dry eye disease can also mimic PUK. Patients may develop silent painless corneal peripheral melt or corneal delum. It is a localized saucer-shaped excavation on the edge of the cornea. They form when protective tear film is interrupted, leading to localized dehydration and temporary tissue thinning. Epithelium is usually intact with a normal adjacent cornea. So coming back to a case, in our patient, in view of recurrent history of redness, arthralgia, following comprehensive systemic workup was advised. Patient was started on topical antibiotics, fortified cefazolin 5% and ciprofloxacin 0.3% hourly, along with cycloplegics and oral analgesics. 3 days later, patient came with a RA positive report and raised ESR, and rest investigations were unremarkable. ANCA was pending. Meanwhile, culture report showed no growth, and patient was continued on same medications. The working diagnosis at this point was left eye peripheral ulcerative keratitis, status post-glue BCL, and rheumatoid arthritis. Patient was started on immunomodulatory therapy, including tablet methotrexate 7.5 mg weekly, DMA RDS like leflunomide and sulfasalazine after rheumatologist consultation. On 2-week follow-up, left eye corneal infiltrate was resolved with healed epithelial defect, so glue BCL was removed. On 1-month follow-up, patient presented with redness and pain. On slit lamp examination, there was congestion. Along with it, there was anterior scleritis inferiorly with a well-localized necrotic area of sclera and surrounding inflammation suggestive of necrotizing scleritis. At this stage, the major diagnostic challenge was to determine whether the process was infective or immune-mediated, as the management of these two conditions differ completely. Infectious scleritis usually results from a direct microbial invasion, often following the trauma or surgery, and typically presents with purulent discharge, scleral abscess, or associated keratitis or hypopyon. In contrast, non-infectious necrotizing scleritis is commonly associated with systemic autoimmune diseases such as rheumatoid arthritis or ANCA-associated vasculitis, including granulomatosis with polyangiitis. It usually presents with diffuse or nodular scleral inflammation without purulent exudates. In infectious scleritis, the diagnosis is confirmed by microbiological investigations such as culture, staining, and when required, tissue biopsy, and treatment primarily consists of targeted antimicrobial therapy. In non-infectious scleritis, the workup includes autoimmune markers such as ANA, ANCA, and rheumatoid factor, and treatment requires prompt systemic corticosteroids and immunosuppressive therapy. Therefore, differentiating these two entities is critical. Keeping in this mind the ocular findings and saddle nose deformity in our patient, she was again advised to get C-ANCA and P-ANCA as they were pending and was asked to review with reports. Considering this, one should be aware of systemic associations of immune-mediated scleritis, which is our first objective. Scleritis is often associated with some systemic pathology, so one needs to know some manifestations of these disorders. Cutaneous manifestations such as skin rashes, ulcers, or depigmentation may suggest systemic vasculitis. Respiratory symptoms like cough or shortness of breath can be seen in granulomatosis with polyangiitis, systemic lupus. Genitourinary involvement, including hematuria, may indicate GPA or lupus. Rheumatological symptoms such as painful joints or muscle aches are commonly associated with rheumatoid arthritis. Gastrointestinal symptoms, including vomiting, jaundice, or blood in stool, may point towards SLE. Auditory manifestations such as hearing loss or swollen earlobes may suggest GPA or rheumatoid arthritis. Neurological symptoms, including headache, seizures, and peripheral numbness, can be seen in lupus and relapsing polychondritis. Nasal symptoms such as chronic rhinitis, nasal ulcers are important clues to GPA. Oral ulcers and xerostomia may point towards Sjogren's or systemic lupus. Coming to the systemic signs, oral, lip, tongue ulcers are commonly associated with systemic lupus and Sjogren's syndrome. A saddle nose deformity is a classic feature of granulomatosis with polyangiitis. Presence of a facial malar or butterfly rash strongly suggests lupus, while facial or scalp hypo and hypopigmentation may be observed in progressive systemic sclerosis. The telangiectasia and rhinophyma are characteristic of rosacea and systemic sclerosis. Cutaneous rashes, associated arthritis, ulcers may indicate an underlying systemic vasculitis. Temporal artery erythema should raise suspicion for giant cell arthritis, and Raynaud's phenomena is frequently associated with systemic sclerosis. Recognition of these systemic signs is crucial for identifying the underlying disease process, guiding investigations, and facilitating timely multidisciplinary management. Coming back to a case, considering left eye scleral lesion and saddle nose deformity, patient was started on pulse steroid therapy with intravenous methylprednisolone 1 gram, and methotrexate dosage was augmented to 10 mg weekly after rheumatologist consultation. On 5-week follow-up, necrotizing scleritis lesion was status quo, and patient had completed IVMP second dose. On this visit, patient came with P-ANCA positive report, making a final diagnosis of both eye presbyopia with left eye granulomatosis polyangiitis associated necrotizing scleritis limited form. GPA is a granulomatous inflammation, tissue necrosis, and variable degree of vasculitis in small and medium-sized blood vessels. It exists in a limited form that is confined to the respiratory tract or eyes without kidney damage, and a systemic form which aggressively impacts the kidneys and other vital organs. ANA, antineutrophilic cytoplasmic antibody, is associated with GPA appearance. C-ANCA against proteinase 3 is seen in 90% of the patients, while P-ANCA pattern is seen in 10% of the patients. GPA can specifically affect the cornea, resulting in PUK. The scleritis in GPA can be categorized into anterior or posterior. Severe vasculitis causes capillary occlusion in deep episcleral vascular plexus. This leads to infarction and necrosis of the affected sclera, exposing the underlying pigmented uveal tissue of the choroid. It may result in scarring, infection, and in rare cases, ocular perforation and phthisis bulbi. Granulomatosis with polyangiitis is a potentially life-threatening systemic vasculitis if not diagnosed and treated promptly. The major causes of mortality include rapid progressive glomerulonephritis leading to acute kidney injury, diffuse alveolar hemorrhage causing severe pulmonary bleeding and respiratory failure, and widespread necrotizing vasculitis resulting in multi-organ dysfunction involving the kidneys, lungs, heart, and central nervous system. Coming to a second objective, which is management of immune-mediated scleritis, the goals of the treatment of scleritis is to rule out infectious etiology and treat the cause, control the ocular inflammation, prevent future recurrences, and also achieve a durable drug-free remission.
Monica,
2022.
Can you speed up? We finished 10 minutes.
Yes,
Can you
yes.
just go to your conclusion, and then we'll discuss this because you're not leaving any scope for us.
Yes. So on 7-week follow-up, left eye lesion was resolving and patient was continued on systemic IMP. Patient was lost to follow-up after 2 years. After this was the presenting clinical picture of the left eye. She came with the complaints of left eye diminished vision. On examination, both eyes were white and left eye showed posterior subcapsular cataract, for which she underwent left eye phacoemulsification with IOL implantation, and she regained vision. Patient at this point was on systemic IMP, including azathioprine, IVMP 6 monthly, and rituximab 6 monthly injections per year. My learning points are to rule out an underlying infectious cause, early recognition of clinical features of associated systemic autoimmune disorder, diagnostic workup, and timely rheumatologist consultation are crucial. Aggressive immunosuppressive therapy for necrotizing scleritis in GPA is considered. Regular meticulous monitoring is imperative to assess the disease activity and treatment response in necrotizing scleritis.
Thank you, Monica. Saujanya, can you quickly let us know the learning points? Now, this is for a general ophthalmologist or residents and students, and not for cornea specialists or rheumatologists. So how would you recognize a case, and how would you go about, when should you refer such a case?
Thank you, Dr. SS, for this opportunity. First, in this case, because the lesion is in the periphery and patient had a history of on and off redness since 8 months with the arthralgia, history of arthralgia, for 2 months. And she had this lesion, corneal lesion in the periphery. Along with that, there were peripheral corneal infiltrates suggestive of ongoing inflammation. That gives us a clue for having this systemic investigations to be done. That gave us a clue of rheumatoid arthritis. RA factor came out positive, so we treated her as a rheumatoid arthritis patient. Here, one learning point from what I learned is to look for peripheral corneal infiltrates and to do the dry eye workup to rule out water tumors and teophanol status. Then next patient we treated as a rheumatoid arthritis and the corneal lesion resolved, but later the patient developed necrotizing scleritis. That is the point which we re-examined the patient carefully. There we noticed saddle nose deformity. So he insisted the patient to get Sianka test to be done. That turned out to be positive, and GPA diagnosed as GPA, which is a rare but life-threatening condition. So the rheumatologist has started on rituximab. But initially they have given IV cyclophosphamide and then started on rituximab.
As I said earlier also, that RA patients generally do not present with RA patients generally do not present without systemic component when they come in with ocular disease. So when you have a patient who has either scleritis or PUK or even dry eye, so they usually, maybe dry eye is only exception, the early dry eye, they usually have symptomatology. So if I have a patient with sort of scleritis PUK, I will initially investigate for both RA and GPA and ANCA positivity, look for ANCA positivity. And RA positivity is, it can be a cross-reactant. So I'm surprised that your rheumatologist did not mention that. So don't treat a patient, don't label a patient as RA just because RA is positive, especially in when the patient comes with ocular features. So this patient, it's very typical. I've had similar examples like that. But for the general ophthalmologist, I think maybe what I learned from your case is, as you mentioned, that the patient has a chronic history, indolent kind of a history, and has the features such as like more limbal inflammation, some corneal infiltration, and what looked like a scleritis feature. Then these are the patients that most probably have something systemic going on. And maybe we refer them to the rheumatologist. Now, had you asked the rheumatologist to do the investigations, they would have done everything in the beginning itself. And they would have understood that RA is a cross-reactivity. So once we do it and we send the patient to rheumatologist, we bias the rheumatologist. So that's a reason to, sometimes it's better to let them do a sort of a holistic examination and investigations. And they usually get onto the correct track much faster than us. That's been my learning experience over the years. Any other comments from our panelists and chairs?
No, I think it's been a great learning that not to take, because RA factor is, I feel, it's a non-specific test.
Yeah, without having a background of systemic disease.
Yeah, systemic, yeah.
But getting into serious ocular disease, whether it's scleritis or PUK, less likely that it's RA. This is
RA, yeah.
my clinical experience had that is telling me,
Absolutely.
rather than what the textbook tell us. So RA is like a sort of it throws you off track, and it often comes positive in these patients with multiple systemic rheumatological diseases.
Yes, yes.
So that's why the American Rheumatologist Association, they actually have a set of minor and major criteria, of which I think RA positivity of some level just forms one criteria. And, they have a scale like we have the ocular trauma scale or the chemical injury scale, based on which they diagnose the disease and ascribe a severity to it.
Okay. But very well managed otherwise, and with an excellent outcome. And the for that because of the strong and aggressive immunosuppression that you provided to the patient, and probably saved the patient's eye. So that was great. Well done. So we have a couple of very good, interesting cases coming on. And this is where, if those of you were missing Bhupesh and Manisha, where they get active now to their areas. So we'll start off with Dr. Abhishek Sagar. Abhishek is from Shroff, New Delhi, Shroff Charity Eye Hospital, New Delhi. Over to you, Abhishek. Sorry.
Are my slides visible?
Not yet. Yes, they are. You go to full screen though. Yes, please go ahead. You have about 10 minutes.
Okay, I am first.
10 minutes.
Yeah. So good evening, everyone. I am Abhishek, and discussant for today's presentation is Dr. Manisha Acharya ma'am. I'm going to present a case that fits exactly today's theme, a peripheral ulcerative keratitis that was commonly missed because it was not autoimmune at all. So moving on to the case, we had a 50-year-old woman with 1 month of right eye pain, watering, and redness. She had already been seen elsewhere, referred in as perforated corneal ulcer, and had been treated empirically as a fungal corneal ulcer for a week before reaching us. Importantly, she also gave a history of fleeting joint pain that had flared 2 months earlier with fever. That detail is what pushed the initial workup towards a systemic autoimmune cause. Given the joint pain and fever, we did a full systematic review, looking for clues to an underlying connective tissue disease or vasculitis. She screened negative on every system. There was no rashes, respiratory or GI symptoms, no neurological or renal involvement, no ENT findings. So clinically, we were in a gray zone, a history suggestive of connective tissue disease, but a completely unremarkable review of systems. On examination, the right eye showed a 4 by 2 millimeter crescentic peripheral ulcer at 5 to 7 with iris prolapse, sallow inferiorly with no hypopyon, and the pupil was peaked. Vision was down to perception of light. The left eye, by contrast, was completely quiet and normal, which is worth noting because it tells us this was a unilateral localized process at presentation. We did a full blood work which showed a markedly raised ESR of about 95 millimeter per hour. But the entire autoimmune panel, including RA factor, ANCA, CRP, anti-CCP, came back negative. This actually created a real diagnostic dilemma. As this, we know that a clinical diagnosis of RA-associated disease can be made even when the panels come negative. So, a clinically connected tissue disease cause stayed on the table. Our working diagnosis for this case was right eye PUK with corneal melt, along with an immature senile cataract. We favored a vasculitic RA-associated process on clinical grounds, the joint pain history, the raised DSR, and the classical crescentic morphology, and interpreted the negative serology as consistent with a seronegative disease. So we proceeded with urgent surgical repair in form of corneal patch graft and systemic immunosuppression. So the initial management we did was performing a corneal patch graft to seal the melt and reposit the prolapsed iris. We started her on high-dose oral corticosteroids, and it was jointly managed with a physician, along with intensive topical steroids, antibiotics, cycloplegics. This is what the standard approach is to presumed autoimmune PUK, where we treat aggressively and involve rheumatology early. Moving on to the course over the next several weeks was not reassuring. At 2 weeks, she developed a PED requiring a tachography. By 7 weeks, her ESR had normalized and she seemed to be improving. But at 9 weeks, despite adequate immunosuppression, she developed an early immune graft melt, unusual if the disease were truly autoimmune and adequately suppressed. By 12 weeks, she did need an AMG and bandage contact lens. This pattern of worsening despite immunosuppression made us pause and reconsider the diagnosis. Now, the turning point came at week 13. She developed a fever and she gave a history of fever and myalgia for the past 3 days and came to us. On slit lamp examination, revealed a classic dendritic ulcer. In a patient already on high dose systemic immunosuppression, dendrite is a dramatic and very specific clue, a finding which is inconsistent with a pure autoimmune process. And this is the moment when the diagnosis flipped for us. So the revised diagnosis was herpes simplex keratitis masquerading as PUK. We added oral and topical acyclovir, continued lubrication, and carefully tapered the systemic steroids while continuing the other drugs. The dendrite healed completely by 14 weeks, and the eye was quiet by 18 weeks. Now moving to the final outcome, the eye was stable at 26. At 26 weeks, she underwent a phacoemulsification with a posterior chamber IOL for that pre-existing cataracts that she had. And she was under continued antiviral cover during the time. Her recovery was uneventful, and her final vision was 6/9, a genuinely good outcome given how complicated her course was. And she was followed up with a oral prophylaxis of 400 mg BD acyclovir. This is the second similar case, a different patient but same pattern, where previously a penetrating keratoplasty was done, and when she developed cataract, we did a cataract surgery. She was uneventful and stable 6 weeks into the surgery. Then she developed a PUK-like picture. Emergency patch graft was done for the melt, and she was started on full dose antivirals. Once again, the eye settled on oral antivirals, the same lesson we learned in a second independent patient. So we already know that the crescentic melting PUK can arise from a broad range of infection and non-infectious causes, which are further divided into the ocular and systemic ones. Infectious causes can be further categorized into bacterial, viral, fungal, parasitic, or systemic. Systemic tuberculosis being an important in our setting, HSV keratitis deserves a place at the top of the list because it can mimic PUK closely enough to be missed for months altogether. Non-infectious causes of PUK we have already seen. Now, PUK is an actual ocular emergency which requires a prompt appropriate management. When a patient with known or suspected systemic autoimmune disease presents with PUK, it is often attributed to a systemic disease or an underlying condition. But it is rightly so because such diseases are most of the time can present as a risk of life-threatening systemic vasculitis, and immunosuppressive therapy is essential to prevent blindness and premature death. Now talking about why HSV keratitis mimics are associated PUK. So because both are immune mediated, both show corneal necrosis with lymphocyte and macrophage infiltration. Both release collagenolatic enzymes that degrade the stroma, and critically, both can show a partial response to steroids. Now, this particular thing, that partial response, is exactly what can mislead a clinician into thinking the diagnosis is confirmed when it may not be so. Talking about a literature precedent, Jeher and et al. In 2005 showed a similar report where they described 2 RA patients whose PUK was initially diagnosed as RA-associated. In one, the ulcer progressed despite immunosuppression, and HSV was eventually confirmed. Though we all know that it is very difficult to identify HSV confidently, here it was done by a PCR in one patient and by histopathology and electron microscopy on the other. Both improved once they were switched to antiviral therapy. The lesson is exactly the lesson from our case. Progression despite adequate immunosuppression should prompt HSV testing. So to conclude, PUK may have occult infectious cause even in a patient with known RA. Thank you.
It's really an excellent presentation, Abhishek. Close to many of our hearts, because probably many of us may have been in the same soup of not having been able to pick it up or not suspecting it because it looked so much similar to the other cases of PUK that we have been looking at all evening. So Manisha, over to you to discuss.
Yeah, so just one thing to add in this patient, when we actually went back and prodded more about what joint pain she's having, so then she started coming up that it was associated with fever, and then it was that time, and then later on when we were just trying to find, that was the time when chikungunya was quite rampant in Delhi. So, I mean, retrospectively, when we were thinking about it, I was just thinking that maybe it was chikungunya to have that joint pain. And at that point, I remember this is around 4-5 years back when we had this case. The joint pain used to last for at least a year. So actually, it actually struck me when my mother had chikungunya, and after that she had this bad myalgia where we were thinking, is she RA? So it was actually chikungunya. So that's another thing which I want all ophthalmologists to also consider when the patients come up with the joint pain, that it can also be chikungunya and not always an RA. So associated fever is very, very important there. Regarding that, I think the next presentation would also be maybe similar to that discussion, but yes, here it was basically the PUK which we were dealing with, and not exactly like it was like a sterilement, very classical of that, and that's something which we had to work.
I'm just going to play the devil's advocate here. Maybe I'll ask Bhupesh. So let's just assume that the patient was doing not too badly. And so what is to stop a viral infection to affect the corneal transplant? So that is also fairly frequently seen. So this could be a patient with some kind of, chikungunya related stuff, but then developed a secondary infection, which is viral and which is very well known. Manisha and Bhupesh, that's for you, both of you. Yes,
Hi.
good evening. Welcome.
Good evening, Dr. SS. So, a nice presentation and very interesting case presented Dr. Manisha. So this, the question is, if PUK is secondarily infected with secondary viral, I think no way we can pick up clinically except if patient is already a known case of herpes or having some telltale signs of herpes, as we know that ghost scarring and vessels and previously. And this is not a classical way of presentation, as we know that classical herpes necrotizing keratitis doesn't present like that. So this is no way mimic HSV until unless you see signs like this. But yes, if your question is that you have done the graft and your patient is immunocompromised and now he's having HSV recurrence, I think that is also one of the very important differential, and that should be kept. And we all have seen HSV recurrences on the graft when the patient is on strong immunosuppression. So that possibility cannot be ruled out. And based on that dendritic lesions, we probably cannot surely say that this was the cause of the first perforation was because of HSV NST or reactive keratitis because of the HSV.
So maybe what we'll do is that we'll have Dr. Namrata Kabra present the last case for the session, which is also similar, infectious cause, and then we can have some more discussion. Good evening, Namrata. Thank you for joining. And Namrata is a cornea specialist. She was originally in Ganpati Netralia. Now she is in Lakshmi Eye Institute and as well as her own practice at Tejas Netralia. Over to you, Namrata.
Good evening, ma'am, and thank you so much for giving me this opportunity to join this wonderful meeting. And thank you, Dr. Abhishek, for already setting the stage. Of course, those cases were very, very complicated. I am here to make a point that we need not wait until the graphs are failing. Can we really pick up the tiny clues which are indicating towards HSV? Can we unmask this disease before it takes a us to little graded complications. So probably a typical looking, all of us, we are primed. Peripheral ulceration is PUK, but not every time. So this was a case presented to one of our colleagues, and it was aged male in 70s with recurrent redness since 3 months, but acute pain since 3 days. History of cataract surgery in past. And as noted by my colleague, there was congestion, PUK, thinning, gutter, and right eye. There was peripheral thinning with opacity, but it was quiet eye. This patient was started with prednisolone, lubricant, and patient has been referred to us. After 3 days, patient presented to us. And let's see, can we unmask it at first visit itself? So if we can unmask this John at the first visit, probably we won't welcome it with the usual weapons. Our weapons will change. That's the only thing. So this patient presented to us, and right eye, which was noted as quiet eye, was also hinting towards something indicative of HSV. There was, of course, peripheral thinning, 8 to 9 o'clock, quiet one with scar, but faint epithelial healing line or early dendrite, and sensations were reduced. When it comes to left eye, this left eye, you can see a crescentic PUK with thinning, with edge infiltrate from almost 2 o'clock to 9 o'clock, and something unusual or different from usual PUK is this area. When you see typical PUK progressing, it is usually circumlinear. But in this case, note it, this is also moving towards centripetal direction, towards center. So this was one clue. Then second clue, you can see nummular lesions, subepithelial infiltrates or nummular lesions, multiple in the center. Third thing, the epithelial defect overlying was way beyond this gutter, which is little unusual in cases with typical PUK. I mean non-HSV PUK. And apart from that, the main clue was reduced sensations for both eyes. So we started this patient considering significant thinning on cyanoacrylate blue BCl. Topically, we started with ganciclovir because it is equally efficacious with less surface toxicity. And this was for right eye. Of course, left eye with blue BCl in place, it makes no sense. Chloramphenicol eye drop was added in view of edge infiltrate in left eye. And patient was already on with moxifloxacin, so we kept it on. We withhold prednisolone for 2 days. So as to attain therapeutic or good concentration in blood with antivirals, and then to add on. Systemically, we started with valacyclovir, doxycycline to inhibit matrix metalloproteinase activity to prevent stromal collagenolisis. And with this therapy, you can see the next follow-up, blue BCl in place, left eye. Unfortunately, at no point of time, the person clicked right eye because the right eye always appeared, it always appeared silent and quiescent to the clicking person. So this is left eye, and later on patient lost blue BCl because epithelial defect was healing, very tiny epithelial defect, and you can see infiltrate has resolved. And the last visit where one can see bandage contact lens, everything otherwise is healed. There is corneal scarring. And last visit we could click right eye as well. So here is small tiny scar in the periphery and early thinning. Otherwise, the faint epithelial defect or dendrite-like lesion healed. Left eye, all healed. Only bandage contact lens was there in the eye. After removal, everything was quiet, and we monitored pressures as well to rule out steroid response. This was very important point already made by and brought to everyone's notice by Dr. Rutu. So try to search for corneal clues. If you search, it will hint towards you. One thing which is very essential is do stain all PUKs. In this case, the defect was quite indicating towards HSV. One can in fact see geographic ulcer with knob-like lesion, not very typically knob, but then this defect is way beyond the peripheral gutter. In this case, you can see peripheral ulceration with early thinning, and along with that, there was corneal edema, which was little discrete, and there was clear interval in between. On examination, there were KPs as well. So all of these were clues indicating towards HSV PUK rather than non-HSV PUK. So just to summarize all these points again, do check corneal sensations, which can help you differentiating between HSV PUK. Do focus on progression of your ulceration or epithelial defect towards centripetal side versus only circumlinear progression, which can give you which can help you towards reaching out to diagnosis of HSV. Diagnostic tests have been discussed thoroughly by previous speakers, so I'll skip this. And of course, once you know this is HSV, then do add antiviral cover. Otherwise, unopposed steroid can result into epithelial breakdown, melt, and perforations. So these are some of the case reports where HSV was masqueraded and considered as PUK, and later on then it was concluded as HSV. So just to summarize again, every PUK deserves a corneal sensation test. Every PUK fluorescent staining should be done. How progression of PUK at the edge is happening should be focused on. Antiviral cover is non-negotiable whenever you are considering HSV, because steroid without antiviral will risk your cornea. And do not miss corneal clues. Cornea actually speaks to you. So thank you. Thank you so much. And I would be happy to know insights from experts.
Beautiful presentation, Namrata, and you've summarized the points so well, I must say. Manisha and Bhupesh, the floor is yours.
I think very well presented, and we've got the right clue of where we said sometimes it masquerades, but I think that case where epithelial defect and it is showing a little bit of geographic pattern, it is very classical of how actually peripheral herpetic HSV infection looks like. There was vascularization, and that goes totally in that. And to our surprise, once you start the right treatment, they respond pretty well. It's the right combination of antivirals. You have to be very strong, like full dose antivirals along with that. When you want, then the steroids at the right time play the key role of getting it resolved on time. So I think it is very well taken that HSV should always be in mind when we are dealing with any sort of peripheral ulceration and should be treated promptly. In the first case, what was there was very different from what you showed, and it's nice to have those blends to understand that sometimes it masquerades, and there at that point it is very difficult to differentiate it from the sterile melt, which may be due to an autoimmune or an HSV. So at that point, to come on that, for our case, what clicked were the dendrites, and when we were least expecting, actually, we were thinking we are missing something. Do we need to? And I think one of the reasons is that you already started high dose steroids. And that at times, even the HSV presentation is very masqueraded when it's post-op, post-PK. Post-PK, they present very differently because they've been on the local immunosuppression is what you call. They've been on local immunosuppression. And in this case, they were also on systemic immunosuppression. So they also, the way in which it is going to present also varies when the patient is on immunosuppression of any side. So thank you so much.
Nisha, had a question for your case. Was the patient already on topical steroids when the patient presented with a peripheral perforation?
No, the patient was not on topical steroids. In fact, the patient for 1 week was on antifungals. But it didn't look like fungal. And also when we did the patch graft, we also sent it for cultures, as is the routine. Even the margin which we were getting, we plated. There was not much of cornea to send, but the margins we always send for that. So it came out to be negative. So the patient was not, it was just on antifungals. So, but we don't know what happened before that. The history was a 1 month to 1.5 months. The treatment history we had was only for a week.
So, Bhupesh, my questions for you are, Namrata mentioned that she does use ganciclovir gel. And most of us from LVPI, we are so used to acyclovir that we have not moved beyond it. I have now moved to Val acyclovir, which is more gastric friendly, I feel. And of course, the patient's profile here is that they're a little bit more affording. So, Bhupesh, your comments on the choice of therapy, both topical and systemic, what do you prefer and what are the reasons?
Yeah, thanks, Dr. SS. So before giving to the answer, I think I should congratulate Dr. Namrata. Yeah, one second. So because the presentation was so good and because it has covered almost all the important points, and the way I think that the important point is if you see the ulcer or peripheral ulcer in a stereotypic scatter examination, and then you will pick up those crucial signs which she was pointing, those KPs, white KPs beyond the ulcer, and the real infiltrate, and the margin having a geographical ulcer. Those are the signs which we can pick up easily. We have encountered fungus behaving like a PUK. We have encountered Pythium and atypical mycobacteria also mimicking like a PUK, and those are the subtle signs which actually give us hints. So if you're having a real stromal infiltrate rather than edge infiltrate at the edge, you think about non-immunomediated or basically infective cause of PUK rather than thinking of peripheral ulcerative keratitis of immune-mediated origin. An anterior chamber reaction usually we don't find in PUK of immune-mediated versus infective. So these are the two important signs. And coming to the question, yes, still where you left, we are still on that point. We are still using antiviral ointment, but yes, cases which are basically coming as or suspected of unknown etiology, or particularly if you're suspecting based on the clinical signs of CMV, we tend to give Verson gel or encyclovir because there's no harm in giving that, and they do respond quite nicely. Coming to oral therapy, well, cyclovir I am using a lot because of the reason of using less dose and also good follow-up and good compliance of the patient. And the price is not that much high, so that patient is usually affording very well. And there's easily tolerability, as you mentioned.
On this note, I do have one query for all the panelists and experts. What if patient is having extreme thinning and at the stage where you cannot think of topical steroids and patient is a non-diabetic patient? Will any one of you consider a short course of systemic steroids and till the epithelial defect and thinning is under control and later shift to topical steroids, or are there any such reports or any experience with such type of approach?
So, Bhupesh, oral steroids, if you cannot, you don't want to give topical at that point because of the epithelial defect.
This question is interesting, but I have never used oral steroids for HSV, but literature is there only for using of when you are having a severe HSV, keto uveitis, as well as scleritis. versus only for necrotizing scleritis or only for necrotizing keratitis, which you are mentioning? Because I don't know how much it going to affect, but yes, I have never used oral steroids for PUK caused by HSV or HSV NSK.
I would like to say from my perspective, and then Manisha and Radhika, that oral steroids in HSV keratitis, even if it's stromal necrotizing, have very little role to play. And the reason why we don't onboard with high frequency topical potent steroids is because that it can potentiate rapid corneal melt. So you do want the epithelium, some signs of healing should be there. Maybe you can start with low potent steroids initially if really we need to. And these patients are not very symptomatic because of the neurotrophic corneas. So they're not complaining too much in terms of pain. So we look at the inflammation and we feel that it's highly inflamed, but after all, it's an infection. So they need the antimicrobial, antiviral first. So that should go in first. And then once the antiviral has gone in sufficiently to kill the virus or to cut down on the virus, and then we can start topical steroids. So there isn't a great hurry to start topical steroids actually.
Yeah,
I totally agree.
You get very good response even only on antivirals. That is, within 1 week you start seeing very nice response with antivirals, and then you are sure that you are moving in a correct diagnosis, and then you can add topical corticosteroids to. I think that's how we are managing these type of cases.
Paras, Dr. Radhika, any differences?
I mean, I would like to comment on the other part that it was a very nice presentation. And there are two important takeaways in the sense that whenever you are in doubt, always use a stain to make sure that you know what are you dealing with. And the other thing is HSV is not so uncommon as we think. So if we consider this diagnosis in mind, possibly we would not be losing many cases to complications.
My point here is, I think Dr. Namrata, which you rightly said, in most of the cases, when you just start antivirals, as Dr. Bhupesh said, within 48 hours, you will start seeing the response. And I have a protocol of not starting antivirals along with steroids. And you'll be surprised to know that even a low dose steroid, if you just add on for 4 times a day, which routinely you would feel it's a very low dose, like a Lodex or something, that also starts giving response. So you don't need a very high potent steroid to take care of it. So oral steroids most of the time are not needed. And I don't remember treating with that in past 20 years or so with oral steroids.
Obviously, in
So the way I look at it is HSV comes with problems which are infective, which are immune, and quite often a mix of both. In its various avatars. So that way, if we see HSV blepharokeratitis is primarily an infective etiology. The ulcer is infective and with a little bit of immune overlay. So like everybody else pointed out, it's the diagnosis that's the problem. Once the diagnosis is at hand, the systemic antiviral does the trick, and once the epithelialization starts, topical steroid is enough. So this is not like stromal necrotic keratitis. There also you can just give topical steroids with antiviral, but there the immune component is equally active. So here it's a primary, infective disease. I want to ask one question back to you, Dr. SS. So Namrata beautifully, outlined the 3 clinical features which led her to the diagnosis, of which I feel that the gutter which is snaking towards the center of the cornea is a dead giveaway. But the other 2, if you are not dealing with a virgin case, all the topical medications can cause a little extension of the epithelial defect. Any corneal ulcer which you treat, if you stain and see after a point of time, the infiltrate and the epi defect, will have a little bit of mismatch. And as a UVA specialist, you must have seen, some of these PUKs having a small component rarely of uveitis also. So unless, like Bhupesh pointed out, tiny KPs like an Arts line, along the area of the ulcer, then HSV is diagnostic. But just anterior uveitis or just an epithelial staining in a patient who's been treated already, do you think it is a dead giveaway, or it can be there otherwise also?
No, I think corneal stain is important. There is no pain without stain. So we must stain. Well, there is no pain actually here. There is no pain with stain, to correct myself. So staining is important to know the extent. And also staining sometimes will highlight whether, so the closest differential we have is like PUK for Murins. So the point that Namrata said, that centripetal versus circumferential spread is I think that's a giveaway, as you said. I don't disagree with what Namrata mentioned. I just wanted to make a point very clear that for dendritic, I mean, everybody knows that. I'm just highlighting it. For dendritic, please don't start steroids, topical or otherwise. For stromal necrotizing, because the epithelium is open, so it'll melt even more rapidly if you only start steroids. There's no collagen synthesis, there's no healing response. So therefore, don't start intense steroids initially, but it needs steroids, no doubt. There is a lot of inflammation. But for endothelitis, you can, I would start oral antivirals or whatever, but I would also start topical steroids. We all know that their immune component is a big play in that. So those are the three differences that we have from epithelial down to. But coming back, pulling you all back to PUK, which is the subject at hand. All the others are out of syllabus now. So I want to just bring you back to PUK. So PUK, as the last two cases demonstrated, seems to be a huge masquerade. And we must keep in mind that not every PUK is Murins or RA or Wegener's granulomatosis, but also HSV, but even fungus for that matter. So we have to keep in mind these infectious causes. Bhupesh, you were saying something.
Yeah, I was very happy to hear that no stain, no pain. That's something very interesting. Yesterday today I saw in OPD one interesting case which was diagnosed as scleritis by so many people and as PUK.
I must interrupt here once. Everyone's patients knew this webinar is there. So Dr. Ritu had a case relevant for today's webinar. And
yeah, I don't know. This is interesting. So my fellow was telling that this is classical case of PUK, but there are so many other signs which we are missing. So the patient was having ocular rosacea and having a Demodex infestation. Actually, that was clearly documented that we do not take care of that thing. And the moment we realize that this is the cause of that, the treatment was very simple. Whether this is causing that or not, that is a different answer. But we have seen that Demodex itself is a cause of marginal keratitis and some not controlled and cause severe scleral and limbal inflammation.
So before we wind up, any other summary points?
Before we wind up, I do have one more request to all the panelists. Either all of you are authors to textbooks in ophthalmology and cornea, or you might be authoring some of the books. I do have one request to make. As all of us we know, HSV PUK is an entity and an important masquerade, but unfortunately, none of the major reviews, they do cover HSV PUK. It's not even covered in PUK reviews, and it's not even covered into HSV keratitis. Of course, HSV keratitis stromal with ulceration has one overlap area, but distinctly this entity is less discussed and is really not mentioned as much as it should have been in literature. So someone coming up with something, I would request to add on this entity as well. Thank you.
So Namrata, why don't you take this up and start writing? I'd be happy to be part of it. So
I can also contribute.
Thank you so much.
So you have the contributors right here. So why don't you start working? We'd be happy to
Great. Yeah, let's
look forward to your message now, right?
Let's take it forward. Yeah.
So
thank you so much, Sheila ma'am.
My pleasure. Any other comments from anyone? If not, we will start winding up.
Yeah, that's okay. Thank you.
All right. I think we had an excellent session today. And I'm really thankful to all the speakers and our patient panelists, and also the young generation that presented the cases today. We had a fantastic 2 hours. And we can't cover everything about PUK, but the intention was to cover a couple of cases dealing with the rheumatological aspects, the systemic disease, and a couple of cases dealing with HSV, as you saw. And we had 2 fantastic opening talks by Dr. Radhika and Dr. Ritu. One was sort of an overview of Murins, and the other one was surgical management. So this was an excellent webinar, at least according to me, and I give myself full marks for selecting and inviting all of you to be part of this. I would also like to thank AIOS, especially Dr. Santosh Honawar, Dr. Manoj Mathur, and the AIOS President, Professor Jeevan Titiyal, for this wonderful opportunity. These are walk-in patients that come to the general ophthalmologist clinic. But what we had today was a wealth of information from everyone, from their practice and experience, and from the books and the articles. So I would encourage all viewers to go back and to look at it. And just to inform you, even if there are very few viewers today, just now, but this goes on to the YouTube channel of AIOS, and it is accessed when people want to read about the disease and when you type in those words. So it is accessed, and after some months, you'll see that how many views they exactly were. And don't be surprised, people come up to you and say, oh, we listened to your talk and at this webinar, and then you'll be wondering, you'll have forgotten about it. So it is a wealth of information, and I thank everyone for researching very well on the topic and then presenting it so that this goes in, on record as an excellent collection of cases. And Namrata, you've hit this topic. You have most of the material already in your presentation, so we'll all be happy to collaborate with you on that. Thank you.
Thank you so much, ma'am.
Thank you. Thank you.
Thanks a lot for the excellent session, Dr.
Thank
Sophia.
you.
Thank you.
Thank you for having
Thank you.
us.
It was a wonderful time.